Okay, so we are going to start with what we hope will be a very robust discussion with our panel. Dr. Bedimo, I'm going to reintroduce you, and then you are going to tell us all about our other panelists today. So just to reiterate, Dr. Bedimo is a professor of medicine at the University of Texas Southwestern Medical Center and chief of the infectious disease division at the VA North Texas. His research interests include rates and mechanisms of chronic complications of HIV disease and antiretroviral therapy. And he's the CRS leader for the AIDS Clinical Trials Group Network for UT Southwestern's unit and is a member of the DHHS HIV treatment guidelines panel. And he is going to lead us in case presentations. And I will ask him to introduce several of our other panelists. We won't reintroduce the speakers for today, but we do have some new speakers joining us for the panel discussion.
All right. So yes, so first my disclosures on these slides are those from Dr. Evans. I will follow Dr. Armstrong's example and share my presentation of Dr. Evans. So these are first our objectives. After attending this presentation, we will hope that we will identify possible OIs according to CD4 levels in person with HIV, list signs and symptoms of OIs in different locations in the body, and explain the management and also describe preferred and alternative therapies. I thought I had, oh, sorry, here's my co-panelist my co-presenter is Dr. Emily Evans, who presented earlier with Dr. Armstrong. And as panelists, I have Dr. Benson, who has already spoken earlier, Dr. Carlos Del Rio, Leon L. Haley, Junior Distinguished Professor of Medicine at Emory, Dr. Dhanireddy, who has presented earlier, and Dr. Boulware, who has presented earlier, and Dr. Masur from George Washington University, and also Dr. Armstrong, who presented earlier. So I will now go back to Dr. Evans, who will present the first case, but since I have control of the slides, I will advance them for her.
All right. Hi, everybody. So here back with another case. And so this is the case of a person who was assigned male at birth, who is a woman who was presenting with new onset seizure. And so she has coming in not on ART with one episode of seizure. She was diagnosed in HIV in 2010. However, she's been out of care for the past several years. She said that she just had one day of mild, kind of unremarkable headache, and then had a sudden episode of loss of consciousness without prodrome that lasted about 2 minutes. And EMS was called, and she was brought in, given midazolam, and loaded with Keppra. Her physical exam was just notable for some tachycardia, again into the 1-teens. Her oral in her oral exam, she did have some thrush. However, the rest of her exam was relatively unremarkable, with the exception of some papules versus developing vesicles over her chest. And her neuro exam was notably absent for any focal findings. Her initial labs were notable for slight leukopenia. Her BMP was largely unremarkable, and her CD4 was 11 with a viral load almost 800,000. Her LFTs were within normal limits, and her RPR at baseline, or her RPR that we had obtained, was 1 to 32, which was significantly decreased from in the past. She did get a CT head that was just notable for a left frontal hypodensity. And given her presentation with new seizure, she did have lumbar puncture with a normal opening pressure and only one white blood cell count, but an elevated protein to 106 with normal glucose. And so this was her MRI. You can see that frontal hypodensity on the CT scan correlating with this lesion that maybe has some enhancement. We'll talk a little bit about it later. And so with that, I want to just open up the first audience participation question of what we think is the most likely diagnosis.
All right, this is my first opportunity to mess it up okay, I didn't. Okay, so
Great.
the majority, Dr. Evans, selected CNS toxo at 43%.
Great. And so if we could just flip back to that MRI really quick, and I'd like to actually turn it over a little bit to the panelists and just, oops, backwards, and ask what you make of these imaging findings and how is this guiding your differential diagnosis for this patient?
So panelist, Dr. Evans is requesting your input.
So Emily, I think you see the hypodensity in the T1, and you see evidence of edema in the T2 flare suppression. So I think there's a lot of edema there. I think, and you see in the middle image, you see the post-contrast. There may be even a little sort of round abscess-like cavity in there. So I mean, I was thinking toxo, obviously, but also thinking about CNS lymphoma as a possibility. Those will be the two big things in my differential at this point in time. The you know, you just have lesions at that level. I suspect the fourth ventricle was open, but there's some ventricular collapse there as well. So, I mean, I think a toxoserology here will be helpful, because if it's toxo is IgG positive, you proceed with treatment. If the toxo IgG is negative, then you will proceed with brain biopsy. I think this is not, I mean, it could be crypto, but doesn't look like a single cryptococoma, and you already did an LP. Syphilis would be unlikely to look like this. It looks more like a stroke. You had other things in your differential there. You know, with the lesions in her skin, I think, you know, you always worry about VZV. And I think one thing to always remember with patients with HIV is they may have more than one thing. So, you know, Occam's razor doesn't fit patients with HIV. So I would say this is primary CNS toxo, but she may also have disseminated VZV or HSV as well.
Roger, this is Henry Masur. Let me pose a couple of issues. First of all, I'm always intrigued by radiologists or pseudo-radiologists who make diagnoses based on the image. And I think that everything Carl has said is very suggestive, but of course, you're always hoping you can find some test that can give you a specific diagnosis, because often the radiologic image isn't as specific as we'd like it to be. One of the issues with these vesicles is certainly you think of herpes lesions right away, but the other question I actually posed to David Boulware is whether this kind of lesion can be a manifestation of systemic crypto. And given all the issues we had with, or he raised with positive cryptangen, negative cryptangen, in somebody who had a relatively acute onset of headache and a seizure, which is typical of some of the things we talked about, not typical of the others. Could this possibly be somebody who needs empiric therapy for crypto if you can't immediately unroof a lesion and look for organisms?
Thank you.
Yeah, so I would check a cryptococcal antigen in blood, so that's a very easy test to do. You know, usually when we see sort of the ring enhancing lesions with crypto, it's unmasking disease. So people who've started HIV therapy, it's relatively rare in people who are not on HIV therapy, and so she's not on therapy, and so I wouldn't say it's compatible, but it's very easy to exclude by a cryptococcal antigen test.
So to the audience, we have already gotten a few pearls. It could be more than one thing, and don't trust the imaging, especially at this stage, and make sure that you check on other things. So Dr. Evans, can we proceed?
Sure.
So I'd just like to make one point though, Roger.
Yes.
And this has to do with the presentation of CNS toxo in the pre-effective ART era. And this woman really fits what we used to see in the
Fits the bill, yeah.
And the most frequent presentation was multiple CNS lesions, not a single ring enhancing lesion. And so one of the clinical pearls that we always used to tell fellows back in those days is that if you see a single ring enhancing lesion, you would think more likely of something like CNS lymphoma, or some other diagnosis aside from toxo. Now, this may no longer be true, but we don't see a lot of CNS toxo these days. And so a single lesion obviously raises that in the differential diagnosis, but I just wanted to make that point.
And also the basal ganglia would be a much more typical
Right.
location
Right.
for toxo.
Right.
No, I 100% agree.
Yes.
The other, I think, interesting thing about this scan is, and again, I think Henry's point, Masur's point is totally germane, which is that the radiologist can, thinks they can make a diagnosis and can't. But this is, if you go back to the images, it's a very weakly enhancing, irregularly enhancing ring. And, the classic finding for a bacterial abscess or for a toxo or things like that is usually a really quite beautiful, similarly enhancing ring, although early, again, it doesn't have to be. And so that sort of stuttered, inhomogeneous sense to the ring, in addition, in irregular, in addition to the single lesion and so on, would tilt me in the direction of lymphoma over toxo or cryptococcoma or histoplasmoma and things like that.
Excellent. So I put our great mimicker neurosyphilis there, but nobody took a bite. So, and I think you all stole Dr. Evans' thunder, so I'll have her continue.
Dr. Dhanireddy, did you have another comment? I saw your hand up.
Oh, yeah, I was just gonna say,
Oh, sorry,
well,
I
you
cannot
actually
see the
put,
hands.
no, that's okay.
Apologize.
You already put it up here. My teaching point was gonna be the EBV from the CSF can be very helpful for when high. Although, it's not sensitive necessarily, but it can be really helpful
Right.
and potentially can avoid a brain biopsy if it's really high in terms of diagnosing CNS lymphoma. So you can go ahead. Thank you.
Fantastic.
So these are a lot of wonderful points.
Girls.
So we did a lot of the workup that was mentioned. This is a toxo antibody that was negative, and then did have an elevated beta D glucan. Of note, in the cryptoantigen was also negative. The CSF results were notable for an elevated EBV PCR, only to 760. And then the VZV PCR on our multiplex PCR was also positive in the CSF. The toxo PCR was also a notable negative when we're talking about other differentials that came up. The cryptoantigen was negative in both the CSF and the serum.
Emily, while you're presenting this, since I'm not a big fan of beta glucan, what direction did the beta glucan lead you? Probably in the wrong direction, but go ahead.
In this case, it was not helpful at all. And I think it was actually run for
No, wait, you can't say it wasn't helpful because you did the test and it's high. So what do you make of that?
In this case,
I can assure you the patient was getting SOSN probably, and that give you a false positive test because came in with a brain abscess. I'm sure the ER put him on SOSN.
Right. Nobody is ever leaving the ED without SOSN. So, all right. Oops, sorry. I got a trouble. Uh-oh. Hold on. Okay. So we've already, I guess, answered this question. What do you make of positive EBV PCR? I think that the panelists have been well ahead of us on this one, but I'll still wait for the answers to populate and then we continue.
Yeah, and while we're waiting
right.
for people to come in, I think the comments are really that both the VZV and the EBV were both positive in the CSF, and how you kind of navigate that dual positive.
And they are number 1 and number 2 in this differential. And then Dr. Del Rio already said that beware of multiple diagnosis. So, okay. And so what I try to do throughout this presentation, we may get to 4 or 5 cases, is just to look at the syndromic approach. And this is important, not only because there's no outcome result, like Dr. Del Rio said, but also because we have a number of things that are more common by regions of involvement, like is the meningoencephalitis or CNS mass lesion, and so on and so forth. Important to note that MRI is a lot more sensitive than CT in these people. And when it comes to brain lesions, we try to look at both mass lesions and diffuse involvement. So that's essentially just a few pearls that, as we will has already been mentioned, the large majority of those with low CD4 count who have focal lesions we have to consider CNS toxo, primary CNS lymphoma, or PML. And Dr. Dr. Evans will discuss further the case progression.
Sure. So given the positive VZV in the CSF, we started her on IVA cyclovir, and we also started pneumocystis prophylaxis. We ended up starting ART about 1 week after, and we ended up doing repeat imaging in 2 weeks after we started the IVA cyclovir, with the following findings. And so I don't know if our panelists want to comment at all on their impressions of our repeat imaging compared to prior.
Yeah, I'll reiterate that this is 2 weeks post the previous imaging you saw.
I mean, I'll just say that it looks a little bit worse, but the other thing is, you guys treated her with IVA cyclovir, but you didn't even describe somebody whose clinical syndrome was encephalitis to me. It sounded like her thinking was not disordered, but rather she had a focal manifestation, which would have further led me away from thinking that the VZV was significant in the CSF. So
yeah, I was going to make the same comment. I'm not convinced that VZV is the primary player here in the central nervous system. Obviously, with the skin lesions, the acyclovir is appropriate, but it's not, I don't think, cementing your diagnosis in the CSF.
Yeah, it's actually been well described to have CNS PCR positivity, even in the setting of isolated dermatomal shingle Zoster reactivation. So I wouldn't make much of that either.
If your place is like mine, everybody in the ICU has already gotten Zosyn and Venk for 1 week with CNS symptoms will also get a cyclovir.
So I think,
I'm sorry, one question. Even if though you think it may be related, presumably you're still going to use IVA cyclovir either to treat the disseminated thing or in case this is related, although as Wendy said, this isn't really an encephalitis.
And I think,
you would continue.
And I think this guy, if this woman had a positive toxo IgG, you would have started her on treatment for toxo, even though, I agree with everybody, it doesn't look like toxo, it looks like lymphoma, but a 2-week course would have dramatically improved things if this was toxo. That's why we think about, when Henry was asking for the specific test for toxo, the most specific test is treatment. When somebody's toxo IgG positive, you put them on therapy and they get better quickly. They get better really quickly. But because this is, as Wendy says, even probably worse, and the IgG is negative, so this is not toxo. I'm continuing to be very worried about lymphoma.
Great. And so thank you for all those comments. And so due to the concern for CNS lymphoma, we decided to pursue brain biopsy about 3 weeks from the initial presentation, which confirmed the diagnosis of CNS lymphoma positivity.
Wonderful panel. Thank you so much. And I think Wendy, sorry, Emily, you can conclude on these points that the panel has already made on MRI findings.
Sure. So just kind of as a general schema for approaching some CNS syndromes in people with HIV, looking at more diffuse meningitis or meningoencephalitis patterns would raise concern from imaging for crypto, TB meningitis, viral encephalitis, or even iris can cause some interesting CNS findings, whereas focal syndromes that are often due to mass lesions are more likely to be CNS toxo, primary CNS lymphoma, and PML as well. However, with the caveat that rules are meant to be broken, and you can certainly have some syndromes that are often more diffuse cause mass lesions. So for example, a cryptococoma, a tuberculoma, even a brain abscess from bacterial meningitis. And when I'm thinking about, for this case, I think it really highlighted also the importance of not stopping at a CT head and also pursuing an MRI. And so just looking at some of the different imaging patterns, for CNS toxo, we really, have the textbook multiple lesions that are peripheral ring enhancement, and that are, as I think one of the panelists brought up, is often in the basal ganglia, but can also occur in the thalamus. Notably, they're usually hypometabolic on PET and cold on SPECT, whereas CNS lymphoma can be often confused with, or often remains in the differential diagnosis with toxo because it can also have some ring enhancement, even though typically in the textbook it's usually more homogeneously enhancing. The lesions can be bigger and there can be fewer with a little bit more of a peripheral predilection. In contrast to toxo, they're usually hypermetabolic on PET and hot on SPECT. And then for PML, which is not really a mass lesion, but rather a non-enhancing T2 hyperintense lesions that can occur. They are often distributed throughout the corpus callosum, the paraventricular white matter. They are often hypometabolic on PET and cold on SPECT. And I just wanted to make a comment that sometimes, if we have PML iris, that can change this a little bit and make things that otherwise wouldn't enhance, perhaps mimic some of our enhancing lesions. And so in conclusion for this case, I just wanted to highlight that multiple diagnoses can co-occur in people with low CD4 counts. I think like everybody had kind of brought up pretty early that even if this person did have a disseminated zoster, that they certainly doesn't change the risk for a possible separate CNS process. CSF analyses can be are very helpful in differentiating meningitis and focal processes. And so I think as we brought up the EBV PCR, can be helpful in decreasing our likelihood for CNS lymphoma, and as well as the diagnosis for toxoplasmosis, which I think a lot of people brought up, is not only a combination of the serological testing, which is very sensitive, but also the treatment trial, and so seeing how people improve with treatment. And then oftentimes, like in this case, if there's a diagnostic dilemma between toxo and CNS lymphoma, sometimes that can require a brain biopsy to really lock down a diagnosis. Just highlighting the imaging differences that we talked about, where toxo is often, several lesions with a predilection for basal ganglia, whereas the CNS lymphoma is often fewer lesions with a peripheral preference. And then just again, to keep in mind how ART initiation can lead to iris and often kind of change the imaging findings.
Thanks so much, Emily. And a couple of questions came in before the webinar, and since they mentioned toxos, I think this is a good place to address them. That they came, I mean, to address the scarcity and expense of pyrimethamine. And both men ask whether there are alternative treatments that could be useful or efficacious in case pyrimethamine was not available. I think that the preferred alternative to pyrimethamine and sulfadiazine is pyrimethamine and Clenda. So with the expense and and scarcity of pyrimethamine, there are limited data on Bactrim, trimethoprim sulfate, 5 milligrams per kilo, trimethoprim, and 25 milligrams per kilo of sulfur, methoxazole. But I don't believe that there is great randomized trials on that. And in vitro, it seems to be less efficacious for what it's worth. So this is going a little lower on the neuronal axis. This is a 55-year-old person with lower extremity weakness and has a CD4 count of 26, viral load of 288,000, has a 3-week history of progressive lower extremity weakness and numbness, no bowel or bladder dysfunction, no systemic symptoms, past history, KS, Hyvan, pancytopenia, is on efavirenz TDF 3TC, relatively non-adherent, and azithromycin, relatively non-adherent, trimethoprim sulfate, the two for prophylaxis, and then gabapentin, cholesterol, calcium. So this is exam as significant for lower extremity proximal weakness, and sensorium is intact. Deep tendon reflexes are normal, and coordination and plantar reflexes are not reported. Upper extremity examination, normal. Cranial nerves, normal. And the rest of the physical examination is not remarkable. So, and this is his lab work. I highlighted very low CD4 count at this point, and viral load of 252,000. A CT of the head is generalized cerebral atrophy with normal ventricles and no increased cranial hemorrhage. And since there was no mass lesion, an LP is done, and CSF shows 42 WBCs, almost all of them lymphs, 237 RBCs, protein 171, and glucose 39. They did not record opening pressure, to the dismay of Dr. Boulware. And this bacterial gram stain and culture negative. And all these other tests are listed there negative. So this is the imaging. And again, I'm just focusing on the highlighted in red, decreased T1 and increased T2 and stir images in the spinal cord from C2 to C7. And this is suggestive of infarct or hemorrhage, according to the radiologist, and no mass effect. So again, to the panelists, to the audience first, what is the most likely diagnosis here? Progressive multifocal leukoencephalopathy, CMV polyradiculopathy, VZV myelopathy, tuberculosis, radiculomyelitis and meningitis, toxo, encephalitis and myelitis, and primary CNS lymphoma. Please vote. All right, so the winner here is CMV polyradiculopathy at 31%, followed by PML. So again, we going back to this, and that we already presented earlier. This is CNS, and now is a little bit lower in the spinal cord. And I'll go back to my favorite book by my fellowship mentor, Dr. Sag and Dr. Masur, because we don't see this much anymore in recent literature, something that walks you through understanding the differential diagnosis of neurologic findings in someone with HIV. The little I understand about neurology is that it's like real estate. It's about location, location, location. So in the spinal cord, we have a neuroimaging that shows focal lesions without mass effect. They really say at that point it's safe to do an LP. And these are usually the three things that you need to worry about, VZV, JC, and the great mimicker neurosyphilis. So for intra-axial lesions that have mass effect, I think we've already gone through this with Dr. Evans, toxoplasmosis lymphoma, but you could also think about things like TB and other granulomatous lesions. But this is without mass effect, and again, those three have to be thought about: VZV, PML, and neurosyphilis and other forms of myelitis. And so this, because Dr. Evans's case and mine both had the VZV, I wanted to present this, which is a differentiation of how VZV, what complications it can have in an immunocompetent person, myelitis, large vesicle, an immunocompromised person like ours, myelitis and small versus encephalitis. And it's possible that the first case might have some of the latter. It's possible that this case might have some of the former, the myelitis. So again, this is likely going through parenchymal infection and infectious vasculitis, or through the dorsal routes. Now, caveat is that I think it was also discussed a little bit in the context of the first case. If you have VZV in the brain or the spine, it may occur before zoster. So not necessarily concomitant with zoster. So the diagnosis here was CMV VZV myelopathy, because in the CSF they got perocytosis and DNA was positive. But it's important to exercise caution, because in case the tap was traumatic and the person has a positive VZV in the blood, that could be a false positive. And again, the prognosis is not very good without treatment. So that goes back to the previous case. I think there was some discussion about whether with diagnosis uncertainty, acyclovir was still could still have been a judicious thing to do. So panelists, any other comments?
I'll just say I find this to be such a devastating manifestation. I have seen so many individuals who never recover. Like, I've seen some people recover, but the vast majority really never recover their neurologic function despite a good response to antiretroviral therapy and getting acyclovir. And so this is one of those diagnoses that always makes me afraid. It's always in somebody young. And so frequently it leads to an inability to walk. I've often been worried about when you start antiretroviral therapy in this setting. Is there an incidence of iris? Because we see VZV flare sometimes after starting antiviral therapy, but I've never found any data to suggest that. I don't know if any of our other panelists have.
Hey, Roger, could you say something more about the use of steroids here?
Yeah, so I think that there's some data. I mean, I think that the main like Dr. Armstrong said, the prognosis of this is so bad that it's not clear what additional important additional value it will have, but it is recommended because of decreasing of the inflammation. Now, there's not a lot of cases, and I'm not familiar with the comparison and whether it works.
I think, Roger, there are a couple of points. Most of the audience voted for CMV polyradiculopathy, which obviously was not the case. The MRI showed a myelitis. And then the CSF was, considering how immunosuppressed this person is, the CSF was incredibly inflammatory with 40 some odd cells, a very high protein. Again, PML is very unlikely with such an inflammatory CSF. If you go back to the CSF, it was a very inflammatory CSF with lots of cells, lots of protein, etc. So when I see a CSF like that, sometimes, I mean, I think the diagnosis here was pretty clear, but the other thing to think about is TB, and TB meningitis can give you a TB myelitis as well. And I think that's one thing to worry when you see a CSF like this one.
Yeah, I'll actually go back to that. But since we already hear back the case, I wanted to highlight the normal reflexes. This can somehow somewhat differentiate polyradiculopathy with myelopathy, because if you have myelopathy, you do have normal reflexes because the reflex arc is below the area that is affected, where polyradiculopathy, like in CMV, typically you lose reflexes. So that's very low. That would be an important thing to consider. And again, the panel is usually ahead of us because, as Dr. Del Rio has mentioned, the other things that you have to worry about, and that's CNS with this type of inflammatory presentation with high protein is TB. They used to call it the Freund syndrome, where you have an encasement of the spinal cord with a proteinaceous material in tuberculosis. So this is, again, all for the CNS. Let's go now to the skin. This is a 34-year-old with HIV and skin lesions. And history of HIV diagnosis in 2009, CD4 count was 81, viral load 21 copies 12 months ago, while he was on abacavir, 3TC, and dolutegravir, and comes to the clinic to reestablish care and off all medications for the past 12 months, developed these skin lesions, in the interval, and the right wrist is about 2 weeks, started about 2 weeks prior to presentation. I will show you the lesions. They're painless, round, raised, and slowly growing, mild bleeding when he pricks them, but no other no drainage noted. So this is what we see here. They're kind of discrete, not too many. Otherwise, virals are relatively unremarkable and breathing 99% on room air. So this is a short one. This is the presentation, and this is the lesion. And in imaging, he has mildly elevated transaminases, 2 or 3 times upper limit of normal. And then viral load is 584,000, CD4 count is 11. They have 2 new hepatic hypodensities with peripheral enhancement, as well as numerous splenic hypodensities. So hepatic density is here and splenic. So this is skin and liver and somewhat spleen. Any suggestions? KS, crypto, Bartonella, prurigo nodularis, secondary syphilis. Let's see answers. Okay, the winner here is KS, panelists.
Well, I have to say those lesions don't look much like KS lesions to me, so I would have put those lower on my differential diagnosis. They do kind of look like lesions I've seen in the past with cryptococcal disease, so I'd be interested to see what David thinks about that. But among your other choices, given the liver involvement, I would worry about Bartonella. That would be kind of my primary thought.
And Roger, just to expand on what Connie said, I think that many of us feel that we can recognize KS by looking at it, but the real experts would always say that you're often right, but you're also occasionally wrong. So it's better to get a biopsy and know what you're dealing with, because you know, whether there's fever or not, whether there's wasting or not, you may be misled. Supporting what Connie said.
Yeah, you're
Yeah, and
absolutely right.
I think both Bartonella lesions and KS lesions are angiogenic, so they are going to bleed. I think you mentioned that they're bleeding lesions, so they're often confused by for each other. And KS is far more common than we see than Bartonella. This person should definitely get a biopsy, but I would agree with Connie that I would be leaning towards Bartonella based on the other findings.
Yeah, I would say that the crypto lesions are generally a little smaller than that, and they don't tend to bleed when people. They're not something that people pick at.
Okay.
And
Thank
I would say the presence of splenic lesions, I think Bartonella is on my short list when I think about particularly splenic microabscesses, which we see in immunocompetent, I see it more in transplant patients, but not hugely uncommonly. Although that wouldn't clinch anything here, because KS can cause visceral disease, etc. as well. I will say this doesn't quite look like it, but just I think an often forgotten skin manifestation in HIV on the extremities is Mycobacterium haemophilum, and it's just worth people keeping on their differential. Usually it's over the joints, but it can certainly ulcerate. It's not it doesn't bleed necessarily, but it can be really quite variable and quite difficult to pick up given the unique growth requirements that it has. And so it's just one to always have in the back of your mind, I think.
Yeah, no, I agree with that. And the other thing is, lesions don't look like it, but there's a question and a comment in the Q&A is, how about mpox? And I think, in this day and age, when you see a skin lesion, you have to think mpox. The CT obviously is not, the hepatosplenomegaly doesn't go with it, but skin lesions, HIV in this day and age, please, don't forget mpox in your differential.
Wonderful. Thank you so much. And so this is, again, a couple of panelists mentioned the fever. There's a lot of things that someone with HIV, from sepsis to TB to MAC, that Dr. Benson presented, Brucella Bartonella, all these other things. So here, long story short, DNA PCR positive and blood and the tissue. So that was Bartonella. So just a brief description that this is usually, this is pretty global description, but Bartonella-Hensley gas scratch disease and can cause in the people who are immunocompromised, both bacillary angiomatosis and the liver lesions that we see here, Pileosis hepatis. There is Bartonella bacilliformis, mostly South America, and Bartonella quintana, the human body louse. Now, the Hensley, the cat scratch could also be exposure to cat fleas and to fleas. So that's important, and most often in people who have a very low CD4 count, chronic illness that could last years with skin lesions, intermittent bacteremia, vascular proliferation in the skin that we saw, and cutaneous lesions, most common, but can affect other organs. So, and this bacillary pileosis is important to note as is in this case. So, and I think forget he's here. Apologize. Z-Pack is what which uses instead of erythromycin here. And I think that the most thing about treatment of Bartonellosis, if it's a simple disease, cat scratch disease, which is a lymphadenitis, just a Z-Pack could do. And more complex diseases like with hepatic pileosis, additional rifampin is needed, and either to doxy or zitro. So, and if it's of course endocarditis, to last for a long-term treatment. And so suppressive therapy should be considered. Yeah, Dr. Benson.
The only other point I was going to make in the differential diagnosis is that, and this is true for you and people like me who live along the border with Mexico, is that we actually do see a fair amount of leishmaniasis. And I know you included that there, but the hepatosplenic lesions and the skin lesions can be very similar to what you've described in this case. And just wanted to highlight that for the audience.
All right. This is the last time I put syphilis in the differential because nobody ever seems to bite. And so that's, I will not put it again. And so discontinuation of suppressive therapy, 3 to 4 month treatment, and CD4 count has risen to above 200, and you should check Bartonella titers if they've decreased. So primary prophylaxis not recommended, and that's the correct standard of care. So let's see if we can go through 1 or 2 more cases. This is a 30-year-old male with HIV disease diagnosed 2 years ago, briefly initiated ART with bictegravir FTC TAF, and was then lost to follow-up. Now presenting with worsening dysphagia, odynophagia, and limiting oral intake, lost 20 pounds in the interval, and then reports intermittent fever, chills, no cough, chest pain, or shortness of breath, and abdominal pain or diarrhea or constipation. So and so, sorry, this is let's say I repeated all these things here. Sorry, it's just that looking at the physical examination here, temperature 38, blood pressure 127 to 76, heart rate 96, respiratory 20, and moderate pallor, no icterus, oral thrush is noted, neck is supple, no lymphadenopathy, lungs are clear, heart's normal, and abdomen is soft, no abnormalities in the extremities. His labs here just notable for low CD4 count and high viral load, and somebody who has interrupted ART for some time, and not significantly elevated inflammatory markers. Bacterial and fungal blood cultures were negative. Hepatitis C antibody negative, hepatitis B surface antigen negative, RPR is negative, and normal cardiac enzymes. Chest X-ray has no infiltrates or effusions. So what would we recommend? So this is somebody with dysphagia, odynophagia, weight loss, and has lost 20 pounds, and has a very advanced disease. And so should we give him the statin, switch and swallow, get an EGD, get oral fluconazole, get antiretroviral therapy? Please vote. All right, so the majority of people would like to take this person to the gastroenterologist. Panelists?
Roger, I'll start. To me, this is more an empiric diagnosis, and this is so often candida that I guess what we would do is just treat them empirically, because unlike neutropenic patients, this is rarely a life-threatening disease. They're not going to rupture their esophagus. They're not going to get candidemic, so that you have time to see if they respond empirically before you do something invasive. Now, I don't know whether that is too empiric for other panelists or not.
No,
I
that's
think
what
that-
I would do too, Henry. I empiric treatment with fluconazole, and then if there's not clinical improvement, low threshold to get an EGD, because as we talked about with other cases, there could be more than one thing going on. The presence of oral thrush indicates that there's definitely candida there, and probably lower in the GI tract. And so that's why I would go with empiric therapy. One thing that gives me pause is that this guy cannot take oral medication. So I'd be really cautious about the ability to do that, and may need some parenteral therapy up front. And then I think, as with the other case, these patients have had access to ART, but are not taking it. And so just fixing this problem of the acute symptoms and the acute OI doesn't address the underlying issue of why he fell off of ART, and what other support that we need to do in addition to obviously these important medications.
Yeah,
Yeah,
excellent
thank-
point, Shireesha. The other thing that strikes me here is, the fact that the person has a really low CD4 count and has fever, and in typical esophageal candidiasis, you don't see a lot of fever. So I'm beginning to worry that there may be CMV or something else going on. So
Yes.
I would start, yes, as you said, with fluconazole, but the patient is not better in a couple days, a week, I would proceed with EGD.
Excellent.
The other advantage to starting with the flu is that, as you guys have mentioned, there may be more than one thing going on here, but candidiasis, esophageal candidiasis, can mask
Right.
underlying ulcers. And so you either have to have an endoscopist who's very willing to scrape that away and look, which can be difficult sometimes, especially if there's a lot of candidiasis,
Yeah.
or treat that first so that you can see the underlying pathology if there is a second process that doesn't get better.
Excellent. So I copied two things from the previous, from the panelists. Number one, Dr. Armstrong first talked about guilt by association. Here, this person has oral thrush and has odynophagia. We have to consider that the candida is also causing esophagitis. This number two is from Dr. Del Rio, that a therapeutic trial, as he mentioned, for toxo is also called for here, and as the large majority of these dysphagia or odynophagia are candida. And to the audience, it's also important to look at here that it's not just dysphagia, food sticks, it's odynophagia, food hurts when it goes down. And that's important in this case. And so this is the follow-up empiric treatment with conazole taken, no symptomatic relief. By the way, nystatin fusion swallow won't do. And so important to take care of conazole. So no symptomatic relief, worsening odynophagia, and what is likely the reason and what's the next step. The panelists have been ahead of us here, and but please vote. All right, this is as lopsided as it gets. So HSV esophagitis, get EGD for confirmation, like Dr. Del Rio had suggested earlier. Important to be quick on endoscopy in these GI manifestations of people with HIV. This is upper GI in this instance. If we get the time, we can we'll get to lower GI, and being said that it's important to push for early endoscopy if things are not looking quite right. So, and again, EGT showed ulcerated esophagitis, superficial ulcers, no pseudomembranes, then the biopsy was confirmatory of HSV1, a complete resolution with treatment. And this is just, I mean, I'll go through it really quickly because it's the #1 differential diagnosis for candidal esophagitis. HSV, CMV could do that as well in the minority of cases. These tend to be middle or lower third of of the esophagus, and it can take the form of clumps of ulcers, multiple ulcers that are confluent or punched out lesions like this one here. And again, the diagnosis of esophageal candidiasis is often made, like Dr. Del Rio said, empirically based on symptoms and response to therapy. So, and this is the 5th case.
Before we go on,
Go ahead. Sorry.
I'll just say, the differential, like you mentioned, includes CMV, but the other really, really difficult ulceration that we see is aphthous ulcers with late-stage HIV. And those actually are common, very, very difficult to treat, especially if the patient with untreated HIV has underlying neutropenia. Sometimes respond to steroids. Sometimes you need thalidomide or thalidomide or something. But honestly, I see more of those these days than I see HSV.
So does anything work?
I'm trying to get somebody both reconstituted with respect to their immune system. Like again, I've often had success in that setting with steroids, although we have a case right now that we're struggling with. And then you have to fix neutropenia if it's present.
Yeah.
Wonderful. Thank you. Other comments? You guys are dishing out a lot of great pearls. So I hope we can go a little lower in the GI tract and stop there because it can't get any lower. And so this is a 40-year-old person of HIV who presents with diarrhea for 3 months. Small amounts of stool, non-bloody, non-mucous, non-foul smelling, non-floating, no change with eating or fasting. So in the day or night, there's diarrhea even when the person is not eating. Low abdominal pain also for 3 months, fever, malaise, night sweats, lost 20 pounds. And no travel, sick contact, or exposure to anything. So diagnosed several years ago, has never been on ART, and also has a syphilis that was previously treated with appropriate 4-fold reduction in titer, hypertension, chronic kidney disease, homeless, lives in a shelter, does not use tobacco, alcohol, or IV, never has sex with men, and has spent 2 months in jail recently. And so he's thin. That's pretty much what we have here. There's not much in the way of focal findings. If we focus on the abdomen, normal bowel sounds, non-tender, non-distended, no hepatosplenomegaly, and the rest is only remarkable for heme positive stools. And this is labs. Despite this really remarkable not being on ART, his CD4 count is not low, not significantly low. It's 325. Viral load is high. And this is the rest of his labs. No significant elevation in transaminases, metabolic profile, relative normal, mild CKD, and but inflammatory markers are very high. ESR is 155, CRP 15, and hepatitis profile or remarkable. So RPR, it was very high, was trace syphilis, now it's 1 to 4. So probably serofast. And bacterial, fungal, or mycobacterial cultures are all negative. These are his iron studies. Iron is low, TIBC moderately low. And got 2 studies, few PMNs, C. diff negative, ova and parasite negative ×3, routine bacterial cultures negative, AFB smears negative, triachrome stain negative. And so had a PPD that is positive 15 millimeters. Nobody can recall whether he has had one in the past. So, and this is the imaging which shows segmental area of involvement in the pelvic iliac loop. Affected segments are narrow lumen, and circumferential thickening of the bowel wall. I couldn't find his image, so I've lifted this one from the literature shamelessly. And so this is the double contrabarrel MR. Again, that shows wide, gaping ileocecal valve and thickening of the valve, but you have thickening of the bowel wall, circumferential thickening of the bowel wall in a 40-year-old with HIV, diarrhea for 3 months with some abdominal pain, and CD4 count that is 300. So what do we think here? Crohn's disease, CMV colitis, lymphoma, disseminated Mycobacterium avium, enteric TB, cryptosporidium. 59% enteric TB, that's the winner, panelist.
I think your CD4 count helps you a little bit here, right? Because CD4 count is over 200. So I think you can quickly kind of rule out CMV colitis, disseminated MAC, those things would not occur at that high CD4 count. Even a lymphoma, I think it's less like, it's not uncommon, but it would be less likely. But I think CMV colitis and disseminated MAC, you can pretty much rule out. Again, this is not presenting like cryptosporidium, at least the cryptosporidium I've seen. And yes, you're left with enteric tuberculosis and Crohn's disease. I mean, the person has HIV, but they can also have Crohn's disease. So don't discard that. Not patients with HIV also get normal diseases. So, but the biopsy is gonna help you here. Now, the problem is if you don't have a good pathologist that really looks for tuberculosis, they'll get fooled and call it Crohn's disease. And I had many patients. I've seen patients with, especially remember very well a patient from Guatemala that everybody was saying had Crohn's disease, and really the patient had enteric tuberculosis. So you really have to press them to look carefully at that, and sometimes you need to go to actually open biopsy to make the diagnosis. But I agree with the audience that enteric TB would be very high in my differential.
And I think one of the clues you highlighted, Roger, is the bowel wall thickening, which really suggests an infiltrative disease and involvement of the bowel wall. And that's more likely to be seen with a granulomatous inflammatory response, like you see with enteric TB. That the fact that the stools were AFB smear negative doesn't persuade me against enteric TB, just because this tends to be, as I said, an infiltrative disease. And unless you actually have ulcers and are shedding mycobacteria into the stool, you may not see a positive acid-fast bacillus. And as Carlos said, that high CD4 count of 345, we tend to see a more localized TB kind of presentation in somebody with higher CD4 cell counts than you might think with Mycobacterium avium, for example. So this fits more with the presentation of enteric tuberculosis. The other epidemiologic features that might fit more with that is, as you said, he was incarcerated for a period of time, which is a high risk factor for exposure, particularly in Texas and California. And the fact that he's homeless and in and out of homeless shelters also, that kind of exposure history is also prevalent among the people we see with tuberculosis in our settings. So that would be more likely for me. Cryptosporidiosis, you tend to see more changes with small bowel than large bowel.
Yeah.
It's a crypt disease, which is where crypto, well, maybe where crypto comes from. It tends to affect the cryptic structure of the crypt structure of the bowel rather than the bowel wall. So I think for all those reasons and the ones that Carlos articulated, to me, enteric TB seems the most likely.
I was just going to add, I don't have anything else to add about the fact that it's most likely TB. I would just want to say that people with HIV, untreated HIV, have dysregulated immune response. And so if they have unfortunate enough to have an underlying autoimmune process as well, when they're untreated, they can have worsened disease. And that's been well described with psoriasis, where people have uncontrolled psoriatic lesions with untreated HIV, and actually treating the HIV and controlling that dysregulated immune response actually improves their autoimmune process.
This is fantastic. As the hour is advanced and you guys already stolen all my thunder, so I'll just conclude that as Dr. Del Rio and Dr. Benson said, this enteric TB is usually doesn't have any pathognomonic presentations. You have to have a high index of suspicion in somebody like that who has an infiltrated disease in the large bowel. And also, like Dr. Benson said, it's a differentiating what could be characterizing that person's diarrhea as a large bowel disease. She didn't really mention how she got into that, but small stools and frequent rather than large volume, because the the colon is just a storage area. So the diarrhea in this area is usually small quantities of stool. This is what probably characterizing of a patient's diarrhea. It's important, and that helps. And also, like Dr. Del Rio said, with a CD4 count this high, it's really unlikely to have many of the other differential items in the differential. And I put here that where the money is in the scoping, just like the previous case with the upper endoscopy. This is lower. Without it, it's really hard to get to the diagnosis. And this particular person lasted months without any diagnosis because there was a bunch of empirical treatments, and there's no way to diagnose, like Dr. Benson said, because we don't have AFB anywhere. And someone like him with a high TB skin test or quantiferon doesn't really mean much, and so it's important to be aggressive in diagnosing this. And in the past, in diarrhea, it used HIV used to present like this a lot. Not that much anymore, and this is just important to say that it can have a high index of suspicion if that occurs. We already talked about the large bowel, which is a storage area, so frequent small volume stools like this person. We're talking some CMV mark, TB, crypto. So that's like here's that's just stools were heme positive. So that's sort of it. I don't think that there is much else except to this. We used to use this a lot when I was a fellow. Nobody uses it anymore, but that we used to say that the CD4 count is where you start when you want to look at what your differential should be. And TB is usually very high because you can develop it, whether it's pulmonary or extrapulmonary in this case, with people with relatively well-preserved immune function. So I think my co-panelist, Dr. Benson, will kick me out if I don't stop here because we passed the hour. I just wanted to have one last pearl that enteric TB is usually low, not up. Jejunum, ileum, ileocecal, like in this person. So and usually, again, not very specific presentation and important to think about it. And then the money is in the endoscopy. So I think I will stop here and see if Dr. Benson has collected some questions.
So there are no active questions listed in the Q&A. There are a couple of remaining ones that were sent in early, and maybe I'll go back to a couple of those. Since we touched on issues related to toxo, I think there are two questions related to your earlier CNS case and whether or not you can use trimethoprim sulfamethoxazole for treatment of cerebral toxoplasmosis. And are there data supporting that, given the high cost of pyrimethamine and things like that?
Yeah, that's I think there is no randomized control trial. There's small studies suggesting it works. In vitro, it doesn't work as well. So that's probably about all I can say. But it's still recommended that to use it if you cannot get the standard of care, but the level of evidence is low.
Can I just ask you the panel a question about that? Does anybody use sulfapyrimethamine anymore? Because it's, for all the reasons you said, it's hard to get. And I'm not aware of very many or any treatment failures with trimethoprim sulfa other than those due to adherence. But does anybody have different experience?
I totally agree. It has been really removed from the protocol at many places, and the experience with many colleagues around the country is that it really seems to be adequate therapy. We have done the same after much trepidation, but I think that, yes, there's not that much published, and no, there is no randomized controlled trial, but the anecdotal experience is actually getting to be quite robust at this point.
So how is the hedge
And I
fund guy gonna
really
make
don't
his
want to give the
money?
money to pharma.
Yeah,
dude.
that's what I say. What's the hedge fund guy gonna get his money from if we don't use pyrimethamine? I
No,
disagree.
we don't
He's
we
in
I don't
jail.
think I don't
He's
think
in
we even
jail.
store I don't think we even store the pyrimethamine in our hospital pharmacy.
No, I think we don't have access to it anymore, so, while the panelists are all here, this is a good question because there were several questions that kind of came and then disappeared about rapid start of antiretroviral therapy and screening recommendations for various OIs in that setting. There's a specific question about screening for COXI, for histo, for crypto, for some of these other things. Do you have specific, first of all, do you do rapid ARV starting in your clinical setting? And if you do you screen for specific opportunistic infections before you do rapid start of ART? Let's go with David.
My-
You can take the first.
My worrisome is
All
crypto, so I'll
those,
let
all
David
those
talk.
fungi before you start, if you do rapid start, do you screen for all those fungi?
So yeah, yes, for crypto antigen, most places worldwide, the other things are gonna be less common. So if I don't live in California, but I've never heard of anyone screening for COXI before starting ART. Histo, in some regions of the world, particularly Latin America, the prevalence can be quite high, it can be 5 to 10% in some cohorts, as well as in Southeast Asia, surprisingly. So the question about histo really is still kind of undetermined because we've also done some retrospective studies on screening in Africa. If people got ART and they did fine, and so if people get ART and they do fine, then there's not really a big role for screening. So I think for histoplasmosis, the jury's still out as to how important that may be, even in an endemic area, if people get ART and do well.
Yeah, and we actually still see, so my area of Southern California looks more like Arizona these days than it used to. And we see a lot of COXI, and we're also right up on the border with Mexico, and northern Mexico is a hot spot for histo. So we still see a lot of histo and a lot of COXI, but we don't routinely screen for either one of those OIs before we start antiretroviral therapy, or we generally screen for them only after we have a febrile patient looking for a diagnosis. So I don't think there's any recommendation for screening for that. But how about the rest of you? If you use rapid start ART, are there other screening recommendations you have related to OIs?
No, we don't. And actually, I find that if there's any barrier to rapid start, it could be detrimental. So getting the patient engaged and started on therapy makes such a big difference. We know from those rapid start trials that saying, okay, we're going to check these labs and have you come back is not that beneficial. So starting same day. Yeah.
Yeah, similarly, we screen for symptoms. We'll draw the labs that day. It will include a crypto antigen because we have a high rate of low CD4s. But we start, if there are no symptoms to suggest meningitis, we start and then call back if, which we'll know by the end of the day if we're concerned.
Yeah, and I think for many of these, almost all of these OIs, one of the most important cornerstones for prevention of an OI or early treatment of an OI is getting them started on effective antiretroviral therapy. So a lot of that comes into play if you're thinking about rapid ART starting. And again, I agree with Shireesha, you don't want to delay that any further by doing all kinds of screening tests for various other things. Okay, well, we don't have additional questions. Most of them, I think, were addressed by all of your wonderful discussions and talks and case presentations. We even covered the majority of those that were sent in before the onset of the symposium. So I think we're ready for closing remarks.